Hello and welcome everyone to tonight's webinar, the fifth webinar in a series of 6 physiotherapy webinars brought to you by Capital Health Network and a multidisciplinary team of hardworking health experts, including physiotherapists, psychologists, specialist pain and sports physicians, and orthopaedic surgeons. I'd like to start by acknowledging the traditional custodians of the land that we are meeting on tonight. I acknowledge and respect their enduring culture and the contribution they make to the life of this city and this region, and I pay my respect to their elders past, present, and emerging. I'd also like to acknowledge and welcome other Aboriginal and Torres Strait Islander people who may be attending tonight's event. Their land was and has never been ceded. So tonight's webinar focuses on neck pain, whiplash, and concussion. My name is Michaela DeLever, and I'm a physiotherapist and quality improvement project officer at Capital Health Network. Also joining me tonight is Rob Erickson, physiotherapist, and Lanhowe Chen, clinical psychologist, and of course, Kanal Mahiti, the events lead here at Capital Health Network. Before we get started, I just want to run through a few housekeeping points. So all participants in the Zoom have been muted. Please address any questions that you have in the Q&A section, not in the chat box of the side panel of your Zoom window. We will have time for questions and answers after both Rob and Lan have presented, and the presentation itself will be uploaded to the Capital Health Network YouTube page, and you're welcome to share this with your networks. In regards to CPD, please fill in the post-event evaluation survey. CHN will email you a certificate of attendance after the event, and please feel free to self-report 1.5 hours of educational activities to your CPD home. Before we get started, I'd also like to mention our Health Pathways website, which has guidelines and advice on the treatment and investigations of many conditions, including concussions and other musculoskeletal injuries. If you'd like to access Health Pathways, the login is together and the password is forhealth, all one word. Health Pathways are a reliable source of up-to-date clinical and referral information that has been localized to the Canberra region. Your feedback is invaluable to keep these pathways updated and reflective of our local health environment. So you'll find a feedback tab at the bottom of every pathway, and we encourage people to use them. So our first speaker for this evening is Rob Erickson. Rob is a titled musculoskeletal physiotherapist and a member of the Australian College of Physiotherapists. He is a principal physiotherapist and director of Capital Clinic Physiotherapy with over 25 years experience in public and private settings. Rob has a special interest in the management of complex and persistent spinal disorders, including whiplash, dizziness, headache, and persistent thoracic and low back pain. He is passionate about physiotherapy and engaging his clients in their rehabilitation to empower them to take charge and move forward in their recovery. Please join me in welcoming Rob.
Thank you so much. So talking about whiplash, the fact that you've signed up to this, you appreciate this is a very difficult population to treat. And the sad reality is that despite the prevalence of structural damage being very rare, after 12 months following an accident, 50% of people still experience symptoms. And so the outcomes aren't great, and it comes at a big cost, over $950 million a year. And with neck pain being one of the most common symptoms that we see in whiplash, this is also one of the leading causes of years lived with disability. So the impact is huge, and the outcomes aren't as great as we'd hope. And you know, so the question is, why is that? Is it because there's structural damage that we haven't found yet? Is it the nature of pain, or is it the context? You know, it's a traumatic injury. And is the trauma a big part of the issue? Is it the patient's fault? Is it what they believe and their beliefs that are affecting the outcome? or is it responsibility? We talk a lot about perceived injustice. You know, a person was just going about their day, having any other normal day, and then they're rear-ended by someone. It wasn't their fault. This is unfair. Why is this happening to me? Does that influence the outcome? And or can we blame lawyers and blame insurance companies and say it's their fault? Do they make things more complex? So there's all these factors at play that, you know, that physical, but then there's the psychological and the social side. So, you know, this is certainly an injury that we need to consider a biopsychosocial approach, you know, more than ever, because there's so many factors at play. And when you think about pain being the #1 symptom that people feel, pain is a protective response of our body. You know, it's the brain protecting the body based on a perceived level of threat and danger. So what are those biological, social, psychological factors that are contributing to threat? And they're the things we need to address the problem. So if we talk about diagnosis, historically, we relied on imaging for diagnosis, looking for structural things, and probably still to this day, the bioanatomical model is still commonly used, but there's a lot of pitfalls to that, and that's namely the overwhelmingly large epidemiological data that shows that findings on imaging is a poor correlator and a poor predictor to pain. And this is definitely the case in the neck and has been shown in Whiplash in some studies where when they tried to predict pain and outcome by looking at imaging, there was a really poor correlation. And just to simply do, this isn't Whiplash specific, but this is over 1,000 MRI images of over 1,000 necks. And if we look on that table on the left, and you go to the bottom axis at 30 years of age, 80%, more than 80% of asymptomatic subjects have disc bulges in their neck. So if you have someone who has a car accident, has neck pain, you send them for an MRI, it comes back that they've got a disc bulge at C5-6, say, it's worse than a toss of a coin as to whether that disc bulge is actually a contributor to their pain. So really at the moment, in terms of diagnosis and using imaging, as of 2024 right now, imaging, it can't prove, but it cannot disprove either the presence of an injury from whiplash. And at Whiplash conferences, the latest one I went to, there were, you know, experts and researchers looking at imaging, and they said, we still haven't found it. We can't find a consistent finding that we think can attribute to people's pain. They'll keep searching, but it's not there. So then a couple of decades ago in Quebec, a whole bunch of experts met up and they set up the Quebec Task Force classification, which I'm sure most people are aware of. And that's this 4-category classification of, I say WOD, so WOD 1, 2, 3, 4. And so WOD 1 basically is someone with neck pain, but without any measurable, observable physical findings. WOD 2 is neck pain with some physical findings, so loss of range of motion or reduction in muscular strength or motor control. A WOD 3 is the same as WOD 2, but then with neurological signs or signs of neurological compromise. And then a WOD 4 is fracture. Now, this is a clinical presentation. If you think about the people that you see day in, day out, we've got this 4-point classification, but what do we see the most? And, you know, generally, well, certainly what I see is WOD 2 by a country mile, maybe some WOD 1. We don't see a lot of 3s, and well, in physio, we probably don't see fractures very often because they're into different care. So WOD 2, it classifies these people, but it's a huge range of presentations, which means you can categorize it, but it's not really helping you in terms of what you're going to do with them. This has been the problem in research, is trying to evaluate treatments on a really mixed population. So there's downsides to this in terms of it's not really telling us who to treat. It doesn't really tell us how to treat them. And if you think about what a diagnosis, the principle of a diagnosis is to guide management. It doesn't predict recovery and probably pertinently because it doesn't take any psychosocial factors into account. It's purely just on clinical physical presentation. But it's still a useful way to classify, so you can put it on paper and people know what you're talking about. But in terms of how it's going to guide us in management, it's not as useful as it could be. So a lot of research has then gone into looking at predictors of delayed recovery. You know, we know that some people get better, some people don't get better. What are the common factors in the people who aren't getting better? Or who have delayed and slow recoveries or not full recoveries. And these have shown to be highly correlated to that. So the first two are high levels of pain, high levels of disability. So if you have someone with a 8 or 9 out of 10 pain and very low high disability, they can't do much. They're in bed a lot. They can't go to work. They're physically not able to do things. These are the people that it's very likely are going to have a long-term, long-time outcome. Whereas if you have someone who has a 3 out of 10 pain, they're at work, but by about 4 in the afternoon, sitting at their computer all day, they get a mild pain in their neck. This person's probably going to get better, likely going to make a full recovery, and in fact, probably make a full recovery with minimal intervention. So the presence of post-traumatic stress disorder is a significant barrier to physical recovery. Cold sensitivity, so this is a reduction in your cold pain threshold. So they're detecting a cold stimulus as painful at a much higher temperature. And this has been said to indicate early central nervous system sensitization, not as easily applicable in the clinical setting, but you can get some sense of that with some simple tests. And then probably lower strength predictors, but low self-efficacy, low education also will be predictive of delayed recovery. Now, looking at this list, what's common with all these things? None of these things are related to neck structure or function. So we can't ascertain by a structural thing whether this predicts the outcome. So this has led to looking at these predictors to look at looking at early in the case, looking at predictive tools such as this. So this is the WIP predict tool, and I'll tell you where you can access this. It's quite easy to do. It's the Neck Disability Index, which is a 10-question questionnaire, then stratified for age. Then for those with the higher Neck Disability Index score, you use the 6 hyperarousal questions of the Impact of Event Scale, which is a post-traumatic stress questionnaire. And that's able to classify people into low, medium, and high risk. Low risk people, generally we should be able to, with just minimal intervention, advice, some gentle exercise, re-engaging people into their normal activities, should get better. Whereas your medium and then to high risk, this is where we need to be enhancing our care, intervening more, and certainly in the high risk, more psychologically informed care. And these things we can identify right from the start. So, and that's so we're trying to move away from that older traditional staged care where you send them to physio or chiro, and if it doesn't work, then send them to a pain management program or an exercise program and move them through there. It's identifying people earlier and directing them towards the ideal treatment as soon as we can. Other simple tools you can use, just individually use the NDI questionnaire, and then the Impact of Events scale, and the OMPQ, the Arebro scale, is a great, again, simple 10-question questionnaire that has some psychosocial questions as well as some physical questions that can be a really good indicator of high or low risk. But all these tools and the WIP Predict tool can be found on this website, mywhiplash.com.au. It's a fantastic website. I thoroughly recommend having it bookmarked and easy access. It has, if you look at the image, you can see there's a section that patients can access with great information, evidence-based guideline and education tools. And then there's a healthcare professional site too, where you can access things like the WIP Predict model. There's a finder practitioner service there too, so you can find specialist physios in your area. But yeah, very, very much recommend having a quick look at this website. It's a really good resource. I'm not contrary to the topic of today's talk. I'm not going to talk a lot about concussion because it would probably take a lot longer than the time I've got for tonight. But in terms of concussion, if you think about it, the forces that are required to incur a whiplash injury are far greater than the forces that are required to cause a concussion. So, and you don't need a direct blow to the head to create a concussion. The forward, backward, the acceleration and deceleration motion of the head and neck can be sufficient enough to create a concussion. And so if someone has a whiplash, it's reasonably likely that, or it's plausible that they could have a concurrent concussion as well. And if you look at this, is a list of common symptoms that are reported in both these conditions, and there's a very large overlap in these things. So it's quite difficult to ascertain in the clinical setting if a person has a whiplash or a concussion, and certainly in concussion, post-concussion syndrome or persistent concussion symptoms, the treatment is impairment based and very similar to what I'll go through with whiplash. Neck pain is a really common finding in people with concussion as well. So in terms of management, what we're going to go through is the guidelines. The current guidelines are actually the third edition, which was set in 2014. So they're a little bit old and dated. So luckily, the fourth edition is available in draft format, and it will be released very soon. So we're just going to run through sort of vaguely sort of what we do as physios and how we should be managing these conditions in regards to these new guidelines. So if someone comes with an acute whiplash, normally they might see you within a few days. We're doing a history. You could be using some of these predictive tools, Neck Disability Index, the WIP Predict tool, looking at their movement, getting a sense of the history and pre-existing conditions. And then what I'd be doing would be applying the Canadian C-spine rule. If they've been to emergency, this should have probably been done. I won't go through this in detail, but this is a tool that is, if you don't know it off by heart, it's really easy to access, and it's very sensitive. If you follow these steps of assessment and questioning, you are very unlikely to miss a fracture. And we do want to detect that fracture, and if they are positive for the findings in the Canadian C-spine rule, send them off for X-ray. And then for this table, if they're on the right-hand side, they'd be a WOD 4, category 4, and we need to start following cervical fracture guidelines. But for tonight, we'll say they're clear of fracture. They're either WOD 1 to 3, and we'll look at in the early days some simple advice and exercise for you to consider some analgesia. If there's high levels of pain, that might change what your prescription is. And then if they're a WOD 3 and they've got neuropathic symptoms, again, that might be something for you to be considering in terms of your prescription of medication. From a physio point of view, in the acute phase, advice and exercise, I will always be, lots of reassurance that it doesn't seem that it's very unlikely there's any significant structural damage. They're safe to be moving, and the sooner we can get them safely and appropriately returning to their usual activity, the better they're going to do. I try and avoid pathoanatomical sort of discussions that can create fear as where it's appropriate. And try and get them moving on their path to actively engaging in daily activities. We can supplement this with some neuromuscular exercise, engaging, the muscles of the neck, the deep muscles and stabilizing muscles of the neck, some range of motion exercises. In the first 7 days, manual therapy, massage, joint mobilizations, manipulation is really contraindicated. It's highly likely it will probably aggravate their symptoms. Their system is on high alert at this stage, and they tend to not tolerate manual therapy as much in those first few days. And there's lots of evidence to suggest intensive, frequent manual therapy starting early in the process can delay outcomes. So, but that said, doesn't have to be totally avoided. Certainly after the first week, you can targeted, gentle, graded manual therapy. When I say targeted, well-reasoned, they've got a specific articular dysfunction, you might be able to address that. But global massage and just poking them everywhere where it hurts tends to not do very well in the acute phase. I try to make the treatment and management as active as possible, that the patient themselves is doing most of the work. In those first few weeks, if they're improving, we just keep rolling along with that. As minimal intervention as possible, getting them to do most of the in an active program. If we're getting to 3 weeks, 3-4 weeks, they're not really improving, we'll start increasing assessment, looking at some more complex testing, looking further at neuromuscular control, looking at sensory motor control and proprioception, which I'll go through in a little bit, and further psychosocial screening. This might be where we might be indicating some other psychological distress that needs to be addressed and referred on. So then we'll skip to chronic, how we manage chronic whiplash. So if someone comes in, and this is probably the majority of whiplash patients I see, they're already 12 weeks or well past 12 weeks. If you think about it, the time of tissue healing has passed, but pain is still ongoing. And so we'll be looking again at classifying them. Are they if they're WOD 1 to 3 and they're recovering, we might continue still on what they're doing, but we might start looking a bit more detailed at what other impairments are involved and start to address those. And we might still consider some psychological therapy if we think that might be indicated in a barrier, even though they're improving. If they're not improving, the guidelines have been recommending now this is the time to be referring to a whiplash specialist. It is a specialist field in physio for more complex cases. And for a WOD 3, so with neurological signs, they're not improving, this is where you may be considering further imaging or if they're failing conservative management. And then maybe here's where you might consider opinion of another medical specialist, which is usually a small amount of people. Surgery is very unlikely to be indicative in this population, but we might get some medical specialist opinions through here. So in the chronic phase, from a physio point of view, education again is a really important part, and this is just one part I thought I'd quickly touch on. What I look at is sometimes this unhelpful cycle that people in whiplash often get to, where pain is driving them into a priority for pain control. So their behaviour, their treatment-seeking behaviour, and everything they're doing is about, I'm just trying to get the pain down. I want the pain to reduce, and it's not working for them. It's not happening. And if you think about that drive and that belief, behind that is harm representations. There's something wrong with my neck. I need my pain to go away. And that can lead to fear. It leads to avoidance behavior. I don't do these activities because it hurts, and I shouldn't do it because hurting, that probably means it's bad for my neck. And this leads to an interference with life values. They're not doing the things that they love doing, that they want to do. They're not doing the things that is important to them and that what helps them see them as who they are, their identity, which usually compounds that negative affect and compounds pain. They get more pain. So we look at trying to redirect what they're doing, and rather than saying, well, instead of looking at trying to get the pain down so you can do the things that are really important to you, what can we do to help get you engaged just in those things that are really important to you? Because maybe if we start trying to do those things, you'll start to feel better. And so behind that is some optimism, some positive affect. We're looking at an approach behavior rather than avoidance behavior. Let's start doing these things. It's safe to do. Your neck, there's no structural damage there that will be worsened by this. If we do it sensibly and appropriately, we can move you into doing the things that make you feel better and make you feel like yourself. And usually that in turn starts to lead to a reduction in pain and certainly recovery and engagement in their life. And this is where we're looking at value-based CBT, where emotions and thoughts are not the problem. The true problem is how these thoughts and emotions become barriers to live according to their values. And the goal is not to remove the physical pain and emotional pain, but to help the patients move in a valued direction with pain. And very commonly, if this is done successfully, pain will reduce. So other things that we'll be looking at is further detail into neuromuscular exercise. So this is testing and sort of lower grade exercise for the deep cervical flexors. So the muscles at the front of your neck and the deepest layer right there next to your spine that helps support and control movement. These are very commonly impaired in whiplash. We can progress this to where they're lifting their head against gravity. Again, this is something there's normative data to say what the asymptomatic population are able to do, and a lot of it's very common in chronic whiplash that they're well below normative standards. We can look at cervical extensors as well, and further afield into the scapular stabilizers, but even looking at general strength and conditioning of the whole body can be really important in these people, and cardiovascular exercise too. And then we'll look at proprioception. So when we look at balance and postural control, in order to have good postural control, our brain's receiving information from 4 systems: vision, the vestibular system, the proprioceptive system, and in this case, more pertinently from the neck, in particular the upper neck, and then the skin. Your muscles, your suboccipital muscles at the top of your neck, have a role to play in moving your neck, but they have probably a stronger sensory role. They are densely populated with muscle spindles and sensory organs. So they're really important in providing the information of where the neck is in space, and therefore where the head is in space. The afferent input from the neck can be impaired by trauma, direct damage, just muscle functional impairment. It's been shown in chronic whiplash that a common finding is fatty infiltrate into the muscle, so muscle tissue is converted into fat. And these things can change the neurological messaging from the neck. Inflammatory mediators can alter this, and pain as well. So what commonly can happen is people with persistent symptoms are often also reporting that they feel unsteady, dizzy. It's usually not a spinning type vertigo like a vestibular issue. It's usually more reported as vague unsteadiness, difficulty concentrating, my head feels foggy, and those sort of things. And so in chronic whiplash, the reporting of unsteadiness has been reported in 70% of subjects. In idiopathic neck pain, it does exist, but much lower. I'd clinically say I experience them probably saying that less than 20 to 30%. But it's also common in chronic cervicogenic headache too, because again, the dysfunction in the upper neck where there's much more a sensory role. And so we would look at if we have someone that has traumatic neck pain, they are reporting unsteadiness or dizziness, then it's very likely with testing, they're going to show an impairment to sensory motor control and proprioception. And then we can treat it, usually doing similar things to the testing, but by practice and graded exposure. So simple balance tests, in particular, I think in Whiplash, you'll see a big difference between eyes open and eyes closed. Your little old lady with vestibular hyperfunction will generally not be very good with their eyes open and worse with their eyes closed. A Whiplash patient will be probably perfectly fine with their eyes open because they're still relying on their vision is fine, but take their vision away, eyes closed, and they're quite impaired. Bottom left screen is half of the smooth pursuit neck torsion test. And it's a two-pronged test that looks at torsion of the neck and its influence on oculomotor control. And so it's a very sensitive test specific test, to neck dysfunction. And then on the right, we're looking at joint position sense or joint position error. So this is using lasers at a target and getting the patients testing their awareness of where their head and their neck is in space. And again, can commonly be impaired and then can be retrained. And then, of course, and then we look at referring on for psychology as well if another component, another barrier that we're thinking is psychological distress. So the things that I went through there were there was a large study done, the impact study, and it showed moderate effects and better effects and it was a better effects with a specialist physio doing the complex assessments, better effects than standard physio care alone. Still probably not the results that they wanted. And I think what they thought was the missing piece of the puzzle probably are the psychosocial factors. We're not addressing them as much. So, and as access sometimes to psychology is not easy and not easy in the early days, researchers have been looking at psychological interventions led by physio. It's not a replacement for psychology, but it could be a precursor or an adjunct. And a systematic review has shown these physio-led psychological interventions, when combined with exercise or physio management, has been more effective than just standard physio management on its own. And that's been shown in the acute and chronic phase. And Stress Modex, which has come out of Queensland Uni, which is what they call a stress inoculation therapy. And it can be appropriately led by physio. It's 6 sessions looking at improving resilience and reducing the stress response. When this has been integrated with exercise, it's been better results than exercise alone. And that's probably where the future of research is going. And so the current research, which is just in the pipeline and about to happen, is the PICO study, again out of Queensland. Queensland's one of the world-leading universities in research of whiplash. And the PICO study is looking at the training of stress modex. So the first stage is looking at training physios in stress modex and how we deliver the training, what's going to be the most effective. Then they'll be looking at how physios are integrating it into practice. And then further down the line, there'll be a multi-centre trial looking at its effectiveness on outcomes. So that's where research is going. We're still keeping that impairment-based model, addressing all the different impairments, but looking at trying to address the psychosocial factors in there too, because this seems to be probably the most common, one of the common barriers to physical recovery. So that's pretty much me. So in summary, just remember, pain is protection. It's our body's protection response. So what is driving the body or the brain to be protecting the neck in this case? And we need to unravel those indicators and contributors to the threat. careful searching for anatomical diagnoses that don't exist. Reassurance is key. As I said, the link, the correlation to structural damage is really rare. So if we can avoid trying to use pathoanatomical language that can be perceived as harmful and generate fear, where appropriate is best. Manual therapy is not contraindicated, but beware of oversupply. If people are having consistent, frequent, and they've had a lot of manual therapy and they're not improving, then we're more likely we're getting them further and further away from recovery, and we need to be thinking about doing something different. Then watch out for psychological distress, and let's refer them on as appropriate. Look out for dizziness and unsteadiness. This can be commonly missed and not reported by the patient, so it's worth asking, and different management could be of use for these people. Keep reassessing. We should be looking every few weeks. Are they improving? If they're not improving, let's move them on to something different. Sorry about that. Let's focus on what they can do, not what they can't, and let's direct treatment and our language and our education towards their life value goals. If we move them in that direction, what's important to them, let's try and make those things happen, then I think we're more likely to get a recovery. So that's it from me. I hope my sound lasted. True.
Thank you so much, Rob. Yep, we could hear you clearly all the way through to the end there. There are a few questions in the Q&A already, but we might jump to those at the end. Our planned second speaker for this evening is Lanhowe Chen, or Lan for short. Lan is a clinical psychologist with a special area of interest in persistent pain. He is passionate about bringing the surprising science of pain and learnings about our nervous system to his clients and tailoring approaches to meet them where they are at. Lan enjoys working alongside the interdisciplinary team of physiotherapists and pain specialists at the ACT Pain Centre. So I'll get Lan to jump in and start sharing his slides now. And when you're ready, Lan, you can take it away.
Perfect. Can everybody hear me okay and see these slides? Okay.
Yep, we can hear you and we can see everything. So you're good to start.
Amazing. Thank you so much, Michaela. An amazing talk, Rob. As usual, I always learn so much from hearing from physios and from being here as well. So that's, yeah, that's a pleasure and a real privilege to be here. So my name's Lan. I'm one of the clinical psychologists at the ACT Pain Centre. And yeah, in terms of my role is to really kind of talk about today just some of the psychological considerations or things to think about in terms of neck pain, whiplash, and concussion. And how I kind of fell into, I guess, persistent pain and the area of persistent pain actually comes from a funny story. Many years ago, I was working in the area of EAP, and I had a client come to me with a bit of back pain. He had seen physios, he had seen all the medical practitioners. He knew that his back was kind of safe, like it wasn't compromised structurally, but he still had this kind of back pain. And me, as a recent graduate, but also going throughout uni, we were always told pain and persistent pain is this kind of black box. And like as a psychologist, you know, good luck going in there. So I was already a little bit on edge myself in trying to treat this person or what to do with this person. So I did the initial assessment and kind of had a bit of a panicky moment, went to supervisors and colleagues trying to, I guess, figure out what to do with the person. And then like two or 3 weeks later, the same person comes back to me and he goes, you know what, Lan, my pain's actually really improved a lot. And, you know, I'm just kind of gobsmacked going, whoa, you know, there's a big difference here. What's happened here? And he said, yeah, I went on this forum called the TMS forum. And I kind of noted that down frantically, being like, I got to know what this is about. And so I kind of like, that was my foray into the area of persistent pain and the kind of psychological contributors and how psychology really has a big part to play around persistent pain, and how, as all health professionals, we can kind of almost educate our clients to figure out and to help them understand a little bit more about some of the things around pain that maybe from a medical model weren't as easily explainable. And so to give a bit of a spoiler alert around the TMS forum, that was some earlier work by a guy called John Sarno, and it was very psychology heavy, probably like the root of like psychogenic pain disorders and how you treat them. And so that was like on the other end of the spectrum of like completely disregarding the medical model and being like, screw them, we're doing our own thing. And so I've kind of found myself coming in the middle around recognizing the complexity of persistent pain. So that's kind of me. And in terms of our session and what we're talking about today, I'm going to give you a little bit of an understanding about how psychology conceptualizes some of the models of persistent pain. Rob's already talked about the biopsychosocial model, so apologies in advance for going straight back into that one. And then, yeah, some specific psychological considerations, especially in that acute phase, of things to be on the lookout for, and also some case studies or examples and just general recommendations that I've picked up on over the time and over the years in doing this work. So kicking things off around kind of models and conceptualizations, I love this quote by George Box, who's a statistician, and he says that all models are wrong, but some are useful. And when we think about pain, it's probably one of the most kind of true things to think about. There's been so many different models out there around pain, and probably, you know, all of them probably fail to capture just the sheer complexity and all the different contributors, all the different things that come into the picture around pain. But certainly some of them can be useful to guide our treatment or to guide our kind of support pathways as practitioners. So as kind of Rob's already alluded to, the biopsychosocial model, this is really the things that come out in the 21st century of studying pain, is that there are three kind of big inputs. There's the biological inputs, which is obviously nociception, and if there is damage, the kind of the sending of noxious stimuli and the sending of noxious signals up to the brain, central sensitization of the nervous system getting more and more wired up and on edge and firing off when it doesn't need to fire off, or firing off at the smallest things. And then of course, inflammation, poor sleep, and genetics. And these are all the things that I trust, you know, the medical people to be on top of, or to at least do the screening for before they even get to seeing me in the first place. But we also now know that, yeah, psychology has a big part to play in pain as well. And even things like attention, so where our attention is. So you probably would have heard patients talking about how, you know, they cope by distracting themselves, watching TV or doing other things, right? And in some ways, there's an element of truth to that, in that when they're not attending to their pain, and when they're not attending to the kind of aversive signals in their body, it probably isn't as noticeable and probably isn't as distressing as well. So attention plays a role. Our beliefs and catastrophizing, this thing of catastrophizing, of kind of blowing up pain or blowing up scenarios in our life, these things can certainly make things worse. This thing called kinesiophobia, so the fear of movement and the associated kind of fear that develops as a result of having persistent pain sometimes, fearing movement, fearing what pain means, or fearing how movement is going to damage the body further potentially. And then typically in practice, we see these kind of two patterns of people who come out. One of them is the avoider, so the person who doesn't, who's been in so much pain that they don't want to do things that will trigger them off or set things off. And so they find themselves being quite withdrawn. I had a client once who was bedbound, literally, you know, almost like the whole time that she was awake, she was in bed because she just didn't want to get out of bed, and she couldn't get out of bed because she was in so much pain as well. And this was, you know, 18 months post motor vehicle accident. And so there's that kind of severe avoidance of not kind of challenging the nervous system and challenging themselves for good reason from their perspective. But then also we sometimes see, and especially from military personnel or elite athletes, elite performers, people with a perfectionistic tendency, this kind of other end of the spectrum of what we call the distress endurer. So they're kind of gritting their teeth, they're kind of white knuckling, and they're kind of pushing through. And that's that classic kind of boom bust activity that you might see in patients, where they kind of overdo things when they're feeling okay, they crash, and then they kind of come back to baseline again, and then overdo things and crash, and it keeps kind of cycling and spiraling. And that actually causes the nervous system to be more and more protective over time as well. Obviously, psychological trauma, and we'll talk about that in more detail in a bit, and also any kind of comorbid mental health issues. And one of the things that really drew me to pain is how kind of modern and up to date, and how people were collaborating to understand it. Whereas a bit of my frustration around psychology has been trying to box people in and not considering, I guess, the bigger picture with mental health issues. And so I think there's now this growing understanding, actually, that our nervous system, the way that we're kind of brought up, the way that we see the world, all of these things all kind of mingle together. And that's why it's useful to put people into boxes or categories to help to diagnose and treat. But sometimes there are some common underlying themes that we want to target to be able to attack multiple things at once. And finally, this one probably doesn't get talked about enough, but especially for whiplash, and I'll talk about that in a second more as well, the social sphere of the biopsychosocial model is hugely important too. And that comes from whether it's stress, financial stress, familial or interpersonal stress, employment stress in the person's life, and a sense of social support or social isolation, and even culture as well. And culture is an interesting one because there are some arguments that whiplash is like a cultural phenomenon or a cultural issue rather than like a purely medical issue. So the way I put this model to patients and clients sometimes is that obviously we have it's almost like we're a car, and so we have the hardware of the car. So that's the kind of, the body of the car, the kind of fuel tank, the engine, and that can be seen as the bio part of the car. But also, especially increasingly now in the car, you have the brains, the computers, the sensors. That's this kind of psycho aspect of the model in terms of the cars. So that's the software, the programming, maybe the cabling or the kind of electricity supply. And then from a social model, it's kind of like the kind of bigger picture. What kind of terrain is this car going on? What's the fuel type that we're using that's going to influence the car? And that's one way of thinking about all these different factors that might influence functioning and performance of a person, and especially around pain. And also, I like to share the story to clients as well around the social one, because it does get a bit lost sometimes in our work, of a social worker who shared the story of a cancer patient once in the hospitals. And this cancer patient, unfortunately, didn't respond to any of the medications they were pumping him with. And he reported 10 out of 10 pain from his cancer related diagnosis, and was just constantly in agony. And no matter what they did, they just couldn't help him. And it wasn't until the social worker came in and had a chat with him, and he discovered that this person was really, really worried about his wife and his family, because he was the sole income earner of their household. And it wasn't until they were linked into supports where he could feel a bit of reassurance that they were okay, that those pain medications kicked in as well. And so really the social sphere, I think we can kind of miss out on when we conceptualize persistent pain and people's pain issues. The other thing that kind of Rob's also alluded to that I'd like to expand on is this kind of DIMS and SIMS model of pain, or the way of thinking about pain as a protective output that's arising from weighing the assessment of evidence for danger against the evidence of safety in the body and to my organism. So we can think of the brain as this kind of threat assessment machine that's constantly scanning the environment. It's constantly on the lookout to say, am I safe or am I in danger? Where am I sitting at the moment? And obviously, a lot of inputs may kind of be part of this threat assessment to figure out, am I safe or am I in danger? So obviously sensory, and from a nociceptive perspective, if I'm getting signals from my neck, if I'm getting a bit of inflammation in my lower back, right? These are things that are going to be adding a bit of sensory and danger kind of inputs to that threat assessment center. But obviously our thoughts and our beliefs are going to also impact that as well. And especially if we're believing that these sensations are coming from a place of danger, that my back's stuffed, that it's never going to get better, right? That I can't bend, I'm not allowed to bend, I've got to be careful, I've got to brace myself. All these beliefs will also factor into the kind of threat assessment of this person's sensations and what's going on in their bodies. We now know that the emotion center of the brain plays a part in that threat assessment too. And there's some research showing that in the acute phase of pain, when you prick somebody with like a pinprick and they don't report any persistent pain issues, that a lot of the MRIs and the kind of brain scans show, I guess, normal pain processing and different areas of the brain around kind of the sensory motor areas of where is this happening, kind of like detecting it in space, and a bit of just kind of understanding the prefrontal cortex of figuring out what to do with it. But when you prick people with persistent pain in the same area, and you kind of compare the differences in the brain scans between these two groups, what people tend to find is that the emotion centers, the part of the brain responsible for emotion processing, tends to be more hot or tends to be more activated. And so we know there's something around the kind of emotional interpretation and the emotional meaning of the pain that might drive a bit of that threat assessment too, and just going to get more sensitized over time. Memory, and this is where PTSD comes in as a bit of a spoiler, in terms of what's happened in the past, or where we experienced this before, or related things in the past, and also our context and our places, the people we're with, who we're around. I've had clients in the past where they can be touched in their sensitive kind of knee or in their sensitive neck by themselves or with their partner, but a doctor or in a medical kind of setting, that it's intolerable for them. And again, it's not about being psychological or all in the head. It's about the threat kind of assessment saying, my home and with my partner, that's safe. At this medical practice, this doctor, that's unsafe. And so that's kind of alerting the kind of higher threat assessment. And of course, the things that you do as well. So all of these things, the brain is constantly kind of weighing up, how much do I need to protect myself? How safe or how dangerous is this situation, or is what I'm going through at the moment? And really, pain is a protective output. It's a way to protect the body, to warn us from these things, and to try to not get us into even more dangerous or jeopardizing territory as well. But when it comes to neck pain then, and in terms of using and implementing and integrating some of these models, I thought I might share and start by sharing some of the kind of known risk factors and the yellow flags, and just essentially some up-to-date information about things to be on the lookout for with neck pain. And I'm categorizing neck pain as a bit different to whiplash, because I suppose I associate whiplash with like that kind of sudden impact, whereas I've also had clients where a neck pain might have developed from a fall or a trip, or even just like insidiously, where they just woke up one day. I'm treating 2 clients at the moment where, yeah, they just kind of woke up one day, had a bad sleep, and then it just kind of never improved. It just kind of, well, didn't get better afterwards. And in fact, it got worse over time. So there's kind of like, yeah, just kind of like a worsening over time as opposed to through a specific moment or an impact. So some of the risk factors are the things that we know will kind of prolong that or make things worse. Might include stress, and we often talk about particularly long-term stress. So both of those clients that I'm mentioning briefly, they were going through extremely stressful times at the time that their neck pain came up, in terms of instability in their kind of social situation, in terms of long hours at work, and this kind of just sense of tension throughout that kind of period of time. And then certainly any kind of mental disorders are also risk factors and yellow flags to be on the lookout for. So whether things like depression, and I'm putting this kind of double-headed arrow to show that it's actually a bilateral relationship. So depression can worsen neck pain. Neck pain can also worsen depression. So it becomes a bit of a chicken and egg cycle. Any anxiety disorders, and particularly generalized anxiety disorder, and certainly any kind of PTSD or post-traumatic stress disorder or post-traumatic stress symptoms, so PTSS, which I'll talk about in a second as well. These things are definitely known risk factors that make neck pain harder to treat or worse in the long term. You may have heard of this term of pain catastrophizing. So we think of catastrophizing as a sense of helplessness, sense of magnification around the symptoms and around their pain. So whether it's feeling like they can't do anything to control it or to kind of make it better, or that they kind of jump to the worst case scenario and they kind of exacerbate what the impact of that pain might be on their lives and on their future as well. Poor sleep, and this is now definitely known to be a double-headed and a bilateral relationship, where poor sleep can definitely affect pain and make pain worse, and then pain can also affect sleep. But we also now know it's a bit more biased on one side. So sleep definitely affects pain more than pain affects sleep. So there is an argument from a psychological perspective, if we can improve somebody's sleep quality, somebody's sleep, that can actually improve the kind of physical symptoms they're experiencing as well. Low social support and a feeling of like not being supported, and that can be that kind of comes in different kind of spheres, and I'll talk about that especially for whiplash in a second. But it might be like familial and support within your local home and family. So I had a client once where her husband was very supportive of them in the first 6 months, but then afterwards started really being quite nasty and kind of vindictive towards this person for having this pain issue, thinking that it's all in their head or they're making it up. And that definitely didn't make things better, made things worse. But also to like employment, social support, so with managers or colleagues, and then to like systems in terms of insurance, in terms of like defense or DVA, and that feeling of not being supported, not being believed, that can certainly be part of the yellow flag that sometimes subconsciously, not necessarily consciously, but subconsciously makes somebody might want to prove that they're in distress or prove that they're in pain through having pain as well. One thing that I want to be very clear on is that of all the studies and of all the research, they found that there's no evidence for this thing called a pain-prone personality. Unfortunately, we haven't found anything to say, yep, you're probably going to get some sense of persistent pain from a kind of research perspective. But certainly anecdotally and clinically, there are kind of murmurings and kind of whispers shared around circles, I suppose, around these kind of types of people, whether it's the perfectionist or the people pleaser, who tends to maybe develop more persistent pain issues, and not just specifically neck pain, but this is more broadly persistent pain generally. People who have this kind of high level of perfectionism, feeling like they're never good enough and being quite critical on themselves, having this kind of black or white thinking, as well as people who are self-sacrificers. They're always kind of giving to others and they almost kind of never attend to their own needs. That kind of people pleaser and that subjugator. These people tend to, and perhaps it's only the ones who end up seeing a psychologist. So we might be seeing people. There might be a population of people who don't see psychologists with the traits that are predictive or yellow flags. But yeah, anecdotally, these are two kind of areas that people have picked up on as well that have been linked with or correlated with persistent pain issues. Moving on to whiplash, and yeah, even as Rob's kind of highlighted that it's been a bit of a controversial condition, and even if you look at like papers in the late 90s, people were calling it a man-made illness, you know, like a made-up construct, which can be quite damaging for a person to hear when they are, you know, when their pain is real. But at the same time, structurally and I guess medically, I guess, yeah, as Rob's already said, that they're still trying to find it, but not really seeing anything to kind of necessitate the discomfort and the pain that people report from having whiplash and whiplash symptoms. And I know there's some controversial papers as well. I'm sure it's been kind of criticized and critiqued very heavily around even like placebo and nocebo car crashes. So where they get participants in, I think it was a study in Germany, where they were in like a lab in like a kind of a fake car or a simulated car, and they were just watching a video of a rear end collision, but there was no movement in the car. And so they could see the impact, but there's no movement in the car. And even after something where there was literally no movement, there was no kind of physical stressor, people still reported pain in the week and the follow-ups after seeing that impact, seeing that collision. And so back in the day, people thought that that meant that it wasn't real or that it was fake or it was all in their head. But from a more nuanced way of looking at things now, through the biopsychosocial model, we can, you know, probably more confidently say, yes, that pain was still real, but it wasn't structurally or wasn't kind of pathologically from a medical issue. And so it was something else that's contributing to that discomfort and pain. An interesting finding coming out from this group in 2017 was that people who self-report a traumatic cause to their whiplash pain tend to have worse outcomes in their muscle function, in neck disability, in mental quality of life, and in depression, experience depression, than those who say it's non-traumatic. So here's where I'm starting to hint at some of the really specific considerations, especially around whiplash, and some things that we might want to be on the lookout for earlier on. And again, in the yellow flags, so those post-traumatic stress symptoms, and I'll talk a bit more about them in a second around some specific things to be on the lookout for. Those things definitely are yellow flags. They're predictors, longer-term predictors of having discomfort and whiplash and pain further down the track, as well as, yeah, these negative expectations of recovery. So feeling like I'm never going to get better, or there's no point, or this sense of hopelessness. And interestingly, in this group that was studying these kind of yellow flags, they didn't find depression as like a predictor or associated with longer term disability, but what they did find was this kind of passive coping style. So it was potentially predictive of these yellow flags. So not being kind of actively involved in treatment, but kind of expecting a fix, expecting for somebody else to fix for them, expecting to be kind of treated rather than the kind of active management of their pain, as well as kind of this withdrawal, this avoidance, this reliance on other people, as opposed to a bit of that self-efficacy in themselves. This group found that pain catastrophizing specifically for compensable whiplash-associated disorders was a yellow flag and was predictive of further disability and pain further down the track. And I've got a scale further down the track around some questions that you might want to ask, or even just a scale to kind of assess for pain catastrophizing, because it seems like it's popping up as a common thread in these areas. And then, yeah, anecdotally, and Rob's already kind of flagged this as well, we do know that the compensation and litigation can actually actively sometimes work against the kind of treatment and medical team. So much so that I've got colleagues now who just say that if you have an insurance, or if you're undergoing any kind of litigation or any kind of claim, let's just put a pause to psychology and actually kind of resume after that's all wrapped up, because it's probably not in the service of treatment to continue doing so in terms of those secondary gains. And it's not necessarily the case that it's intentional or that patients want to be unwell. but also sometimes we do hear stories, kind of horror stories of solicitors kind of warning patients, you better not get better too quickly, you know, otherwise your payout might not be as much. And that can really actively get in the way of treatment and get in the way of outcomes too. As well as, so on other areas too, the sense of perceived injustice. So Rob's already mentioned that as well. The sense of unfairness, the sense of like, there's sometimes kind of almost a bit of self-pity around why me? Why did this happen to me? I didn't ask for this. I didn't invite this, and this kind of sense of pity. And I would probably tie that into this kind of passive coping style of this withdrawal, this kind of external locus of control, rather than a shift towards that internal locus of control. And certainly those comorbid mental health conditions like depression and anxiety definitely throw a spanner in the works, or they model the picture as well. So if you have neck pain, or if you have that whiplash as well as depression, right, then these two things start to kind of really make it hard to do those approach behaviors, to kind of start to engage with treatment, because their mood may be so low, they may be suicidal, there may be hopelessness, there may be kind of just significant distress, and that kind of gets in the way of doing the work to be able to give the nervous system a bit of a reset or recalibrate it to move forward with life. I thought I would also share this mutual maintenance model of PTSD and chronic pain, which was shared more than 20 years ago now, and just to kind of highlight some of the underlying factors that probably contribute to both PTSD and persistent pain. And this is more kind of general around chronic pain, but I find with whiplash, this is probably quite helpful to highlight or to zone in on the things that might be keeping the problem going. So in terms of number one, the attentional and reasoning biases. So typically if it's a motor vehicle accident, right, if we go, well, even as humans, when we go through something that's difficult or something that's stressful, it's quite normal for the brain to start to hone in on that kind of one negative thing that happened, even if in our lifetime there were thousands of times where, you know, it wasn't catastrophic or it wasn't bad. And so even just the kind of shifting of our lens attentionally towards the kind of negative, towards the kind of bad, towards the dangerous, this happens both for people with persistent pain, but also with PTSD as well. And it can kind of be a driving factor for both of these things. This thing called anxiety sensitivity, and I would probably, this is 20 years ago now, I'd probably replace that with kind of like just sensitivity around signals in their body. So it could be this kind of fear response that clients feel a bit more sensitive about, or they kind of get quite frightened about, that kind of the beliefs that, you know, that it's bad to feel stress, that it's bad to feel this tension, or it's bad to feel this pain. So that kind of sensitivity to signals in their body, and feeling kind of distressed by that, or feeling not knowing how to cope with that, that would be a driver of both persistent pain and PTSD as well. Especially with whiplash and especially with motor vehicle accidents, the reminders of the trauma can kind of set off both the PTSD in terms of flashbacks, in terms of those intrusions, but also in terms of the pain as well, and that pain network. And really interestingly, when I do, PTSD trauma work with clients, a lot of the times they'll be noticing pain as they're doing like an exposure task or exposure homework task. So the pain system and the kind of PTSD arousal emotional response system, they kind of both get taken along for the ride when people are reminded of the trauma or reminded of the significant stressor. I've talked a little bit about already around avoidance, and so this is a kind of natural pattern that happens when people feel quite distressed. You know, if it's passing by that site that they had that motor vehicle accident, or if it's about even getting into a car, but we now know that the pain, when people avoid, they don't tend to challenge themselves. The nervous system doesn't get a chance to kind of reset and recalibrate. And from PTSD, it usually maintains the problem as well. Avoiding it kind of makes it a bigger problem in the head to say, well, yeah, when I avoided, my distress levels went down. And so that's teaching me that avoidance is a healthy strategy to not make myself feel so distressed about this trigger. Depression, reducing activity levels, I've already mentioned that as well. And that anxiety and pain perception around, the heightened perception and the heightened kind of threat processing in the brain that kind of causes an elevated levels of arousal, elevated levels of needing to protect the body. And then finally, this one's probably something that we don't touch on as much, is that it is actually quite cognitively demanding from having these symptoms, right? And that's where this sense of like brain fog, this difficulty concentrating, issues with memory, right? These things are quite typical when the brain's literally on this high alert constantly, or when I'm experiencing physical discomfort and pain, constantly throughout the day, and I'm trying to manage it, trying to kind of live my life with it, that is cognitively quite demanding. And so that can actually stop us or reduce the use of helpful things that might have been useful in the past, just because these are so demanding. And so some of the things that we as psychologists do, it's not necessarily rocket science, but sometimes we have to really meet clients where they're at because of the sheer demands and the cognitive demands of what's been going on for them. So hopefully that helps to kind of give a few of the kind of underlying processes that might be contributing to both PTSD and persistent pain when these two things co-occur. And it really kind of drives the need for psychological intervention and psychological support in these settings as well. I forgot, so in terms of PTSD, so the four kind of main buckets that we tend to look for when people have PTSD is one, the intrusions. So whether it's intrusive memories that are uninvited, that are quite distressing, or having flashbacks, or even nightmares and kind of dreams and disturbances when they sleep around this kind of the incident that happened. Avoidance, and this is both avoidance of maybe external triggers or avoidance of internal triggers. They don't want to feel that way, so they kind of numb themselves, or they don't want to pass the site of the motor vehicle accident again, and they kind of tend to drive longer distances or further out. They ask somebody else to drive them, or they close their eyes so that they don't have to be there. These are kind of some typical patterns of avoidance. And then the third bucket is around mood and kind of cognitive changes. So in terms of their mood feeling changed, there might be the sense of irritability, feeling quite down, or it could even be cognitive changes around developing these beliefs that the roads aren't safe, it's not safe for people to drive, people are assholes on the road, right? So these kind of global generalized statements about the world or about themselves. I'm never going to be safe, I'm not safe in a car, as well as this kind of physical and behavioral changes. And that's where pain might come in, but as well as a sense of tension, this kind of heightened being on edge, that the smallest thing can kind of set people off. These are the things that we'd be on the lookout for around some of those PTSD symptoms. And in terms of the area of concussion, so unfortunately, especially with the ACT Pain Center, by the time people have gotten to us, they're probably in that kind of post-concussion phase. So I don't have much to say around the acute phase. And really, there's not much that I would be able to contribute to in that kind of acute phase, I imagine. But one thing that we found is that potentially getting a neuropsychology assessment could be helpful, especially when somebody has had like a mild traumatic brain injury, and they report things like their memory is different, or they kind of can't concentrate. That it could be helpful just to get that neuropsych assessment to look at whether there is impairment and how that's going to affect not only themselves, to give them an understanding that, oh yeah, this is actually real, but also to help guide the treating team as well. Because if we're expecting them to be switched on, understanding stuff, but their processing speed is slower now, or their kind of retention, their memory, their ability to focus is impaired now, it's helpful for the treating team to know that this has been done and that this is some deficit that they're experiencing because of the post-concussion syndrome or because of their concussion. But also, just to kind of backpedal a little bit too, we also know that comorbid depression can also lead to memory issues, concentration issues, difficulties focusing, and so that can really muddle the picture as well. So if somebody's got depression and they've experienced a concussion as well, it's like, which one is it? Is it from the concussion itself that there is these neuropsychological impairments, or is it actually the depression that's driving a lot of this kind of fogginess, this difficulty concentrating, this poorer memory retention, as well as potential side effects of medication as well. But really the lasting words that I'd say around that, around the kind of trajectories with persistent pain, that those yellow flags probably are all quite relevant. And so we want to treat it pretty similarly in terms of, especially from a psychological perspective, for how we deal with that, especially in that post-concussion or chronic phase. So in terms of where psychology fits in and what my role is within the team, ideally, and this is what the evidence says as well, is that psychology works as part of an interdisciplinary team. We're not going solo with it, but ideally working with physios, working with a pain specialist, or even the GP, working with other kind of care providers to provide this holistic and kind of different angles of the care. And from a pain-specific point of view, part of what a pain psychologist, in quotation marks, because it's not necessarily a thing, it's more a psychologist with a special area of interest in pain. ideally what somebody would do is around giving quite targeted pain education. So providing information after listening to the history. And I suppose where psychologists might be different from physios or GPs is that we have a little bit more of the luxury of time to kind of dig into the person's history, to dig into their beliefs, and to dig into some of those weird things that might be happening for them that they might have been too afraid to bring up with their doctor or to their physio for fear of being, labeled as crazy, or that this is just their anxiety speaking. And so kind of tying some of those things to the biopsychosocial model or to that kind of threat assessment model to go, yeah, no wonder, when you're sitting at home on a couch, right, you can sit for longer versus when you're sitting in the backseat of the car, even though maybe it feels the same or it's just similarly comfortable, but one is a lot more tolerable than the other one. And from a medical model, it might not make so much sense, but from like this threat assessment model, from this biopsychosocial model, that makes complete sense. And so part of it is that targeted pain education to validate actually what they've been going through and to get a bit of that buy-in for the next steps, which is often around movement and physio, as well as some of the psychological things as well. So that includes things like, the challenging the meaning and the fear of pain. So if people have been told that, their necks are no good, that they have to be really careful about what they lift, or really be careful about where they, what they do with their necks, or how much range of motion they have in their necks, then they might become quite guarded around that. And that's working together with the team to challenge that. And if somebody's quite heightened and quite anxious, it could be about creating like an exposure hierarchy and working through that in small steps to approach these things in safer ways. And I'm going to talk about the avoidance and the boom bust activity in a different slide, but that's also a really, really big thing that that we also have a bit of that luxury to be able to kind of work through, because most people, by the time they get to us, something's kind of gone wrong that's kind of prevented them from potentially going onto the track of normal recovery. And so there's probably been a barrier or an obstacle, maybe in their expectations or in the way that they see themselves, that's really preventing them from being able to do things in a very consistent or in a graded way. And so I'll talk a little bit more about that in the next slide. That's the kind of pain stuff specifically, but then also kind of in conjunction or alongside that, there may be things like stress management techniques or things just from a physiological perspective to help to wind down the body, whether it's like those breathing exercises or progressive muscle relaxations or imagery and kind of visualization exercises, through to mindfulness practices, and also in terms of those self-compassion practices as well. So people tend to get really quite hard on themselves and quite critical of themselves, especially as their pain develops and it kind of doesn't improve. And sometimes that can be part of that depression, that kind of being quite critical and quite harsh on oneself. And so self-compassion, we now know, is actually a stress reliever and can help with improving their stress response too in navigating those day-to-day challenges. We definitely want to treat any comorbid mental health conditions, and especially with the lens of pain as well. So especially like it's easier if somebody's got depression and no kind of pain issues to say, let's do some physical activity, or what would that look like for you? And that it's helpful. So how can we integrate that into your life? But there's like 10 things that are not more complicated about doing that for somebody with persistent pain. And so kind of really being mindful of that, of how we might treat those kind of comorbid mental health conditions. And especially PTSD and trauma-related symptoms as well. So those things are definitely maintainers for persistent pain. So if we can kind of settle the PTSD stuff, then we can start tackling the other things that might be contributors there as well. And finally, just a lot of people, especially with car accidents where they weren't expecting it, there's this huge kind of shock and this huge change to their life. And so psychology can sometimes be part of that grieving process of going, this was who I used to be, and for the past year now, for the past 2 years now, right, this is all the things that I can't do that I used to love doing, and kind of re-navigating what life looks like now to adjust to that new reality. But then also in terms of moving forward, in terms of being values focused, in terms of problem solving, trying to shift that person towards not just kind of in that sadness loop forever, but shifting towards problem solving, towards moving forward, towards learning new skills to be able to navigate this kind of life 2.0. Maybe we sometimes think of it as life 1.0, and now this is life 2.0 to learn new skills. So some of the modalities that you might see a psychologist talk about or using might include cognitive behavioral therapy or CBT, acceptance and commitment therapy or ACT, different various trauma therapies. I have a whole slide talking about these in a bit more detail in a sec. And really, I guess the kind of pain angle or the pain spin is integrating some of the pain neuroscience education with, because we have a bit of that luxury of time, a little bit more of the luxury of time, with that kind of psychological spin and adding those kind of angle of beliefs, of the emotions and the emotional reactions towards how somebody's interpreting their sensations in their own body. And just kind of tapping onto what Rob's model there around the kind of avoidance pathway, which stops people from getting better. Sometimes what we have to do is really target the fear response that they have, or the kind of negative affect that people might be experiencing kind of more globally. And that could be a sense of depression, it could be a sense of heightened anxiety and worry about the future. It could also be the sense of irritability or anger, right? Anger towards the world, anger towards insurance, anger towards the kind of person, the perpetrator. So all of those things are things that we would, as a psychologist, kind of identify and kind of work through to try to soften that, or to try to see if we can kind of reduce this as a roadblock to then be able to shifting to the other side around living life, living the valued goals, finding a direction, or finding things that are helpful for that person and important to that person, and fostering that. And again, people might not have the fear or the negative affect, but it could be that their prior history or their own expectations might be getting in their own way of them doing that. So I've had plenty of clients in the past where they may have come from an elite kind of athlete background, where they kind of push and push and push. And so they expect themselves to be able to just get on with it and do it and kind of push themselves. And so, as I said before, they kind of fall into that boom bust pattern of activity that then prevents them from actually doing things consistently and in a graded manner to approach and to do things that are important to them. And the kind of interesting thing, and Rob also mentioned this too, is that with psychology and with this kind of treatment, is that if we're making pain the focus, it often keeps the kind of focus stuck on pain. And so if we need, part of the kind of discussion that I have with clients is that yes, I'm a pain psychologist. I work in the area of pain, but I'm actually about, I think of myself as a life psychologist. How do we get you to live life fully, where pain might still be there for the kind of short to medium term, but as we continue doing this, that pain starts to kind of subside into the background. And I had a client a beautiful farmer, who kind of said that he related to that really well, saying it's kind of like a horse. If you look the horse dead ass in the eye and you approach that horse like pain, right? The horse is going to bolt and it's just going to run off, and you're not going to have a chance of taming that horse, or being kind of being able to work together with that horse. Whereas sometimes you have to be a little bit more sneaky and pretend like you're checking out the flowers there, and you're kind of like easing up to it and getting a bit closer and closer to the horse to be able to calm them, to be able to kind of tame that horse as well. And that's the analogy that I sometimes use with my clients as well, is that this is, if we're saying we've got to make pain go away to live life, or pain's the kind of focus and we need pain to stop, right? We're actually just going to make the system even more hyper-focused, more hyper-vigilant around pain. Whereas the focus now is about how do we live life, and pain might be in the picture, and all the discomforting emotions, all the kind of difficult emotions that might come with that, we're going to have to deal with that. And we have ways of dealing with that, thankfully. But if we can kind of still keep our eye on the prize around, playing with my kids, or in terms of contributing at work, if these are the things that are important to me, and we can kind of build on that, then pain over time will start to subside in the background as well. So I just wanted to kind of bring a few cases, and kind of put this from theory or abstract and a bit more grounded with some examples. This was some clients with a few modifications, just that I've seen in the past, and some notable examples there. So I had a 34-year-old man who was a painter, and he had persistent neck pain after a fall at work medically, and he'd been through his GP. It was clear in terms of his MRIs. There was a small disc bulge, but he was quite accepting that, yep, we all kind of get bits and pieces of bulges, and so that wasn't the thing that was kind of concerning or threatening for him. But one thing that his GP did say at one point was that, and he even might have not, I don't even know if it's true or not, but this is something that had stuck with him, was that my doctor told me I've got the neck of an 80-year-old bricklayer. So it might not have been about the disc bulge, but it might have been something else. And this thing was something that he held on to at the moment that we kind of spoke about his neck and about what he's been told about it. And no matter what we talked about, or no matter what we did, this always came back to, well, I've got the neck of an 80-year-old bricklayer, right? So I've got to be really careful, really guarded around that. But it wasn't until we kind of did a little bit of work to kind of understand that threat assessment center, the kind of different things, the way that beliefs and our thoughts can influence pain, that he realized, okay, so this is one thing that I've been told, but then the physio, the pain specialist, the kind of the imaging, the radiologist, right? Being able to kind of gather information to kind of say, okay, is that even true? Is that even helpful, actually? And in terms of being able to kind of refocus or relabel the language that he used around describing his neck, it wasn't until we did that he started to get a little bit more kind of movement and traction in his work with physio. So being able to kind of be less tense in just how he's holding his shoulders and holding his neck, right? He would always come into sessions like this, just kind of really, really with the shoulders up and just constantly kind of on guard and tense. And so that pain education, that kind of safe and mindful reconnecting with unpleasant neck sensations. So from a psychological perspective, that's where we implement some of those mindfulness skills to connect with those sensations, knowing, and again, this is where the team's involvement is really crucial, knowing that, yep, it may be uncomfortable, but it doesn't mean that your neck's about to blow out, right? You don't need to go to emergency department for this. It's an uncomfortable sensation, but how do we teach your body and teach your brain that this sensation is actually not as dangerous as it's making it out to be? And so by safely reconnecting with that, that was part of the work that we did, as well as that kind of just general overall bodily tension, just being really, really kind of tight and kind of upright. So those kind of relaxation exercises. And then with him working with his physio to build that confidence, that capacity, that strength in his neck, and then as well connecting with what was really important to him. So he found playing with his daughter, being able to look down and kind of play with his daughter was really, really important. And so we kind of tried to integrate that into how life was important, what was important for him in his daily activities. Another case example is a 45-year-old man with whiplash and shoulder pain after being rear-ended in a motor vehicle accident. And unfortunately for him, for the first 12 months of his care, he had a revolving door of GPs. Just for some reason or another, he'd see a GP, and then the next session he'd be kind of referred on, or they had to close their books. And I think it was just a real bad case of bad luck that for 12 months, he just couldn't get that consistent care for GPs. Within a couple of weeks, they would have been referred on, or maybe a GP would have started something, but then he would have changed, and so a new GP would come on board, and it just really made his kind of recovery quite difficult and more complicated than it even needed to be. So unfortunately for this guy, he actually started developing anxiety relating to medical practitioners and his healthcare team. So this person started to get quite kind of tense. Every time he had to see somebody new, he'd get quite panicky in the waiting room. And even when he was getting procedures done, he'd have panic attacks sometimes, just from the kind of severe anxiety that developed from that uncertainty and from that kind of revolving door of GPs. And to top things off as well, so when I first saw him, he did have post-traumatic stress, and I would say post-traumatic stress disorder, but some of the symptoms included difficulty sleeping. He had nightmares of the kind of motor vehicle crash. He definitely avoided that location. He had not come back since the motor vehicle incident. And every time he kind of woke up from the memory or woke up from the dream, the bang was the thing that really kind of stuck with him. So just that bang, and he could feel his whole body just kind of getting elevated every time he kind of brought back that memory and just kind of even remembered that bang sound. It just kind of heightened his whole nervous system and body. And he could see the relationship between this and his pain too. So it evoked that stress symptom. And then as part of that, his neck pain would then get worse. He would feel, oh gosh, I'm so stiff and sore now in my neck there too. So for him, you could kind of see the relationship, and there was that buy-in between let's kind of deal with the PTSD and these post-traumatic stress symptoms to try to help to reduce the triggers for that neck pain, and then to deal with that later on. So what we did was we did some prolonged exposure to reduce the intensity of those symptoms. So what I got him to do was to actually walk through the motor vehicle accident in a very systematic way as a psychologist, to be able to kind of run through it while monitoring his distress. And he had to record himself and actually listen to that recording and actually continue to kind of desensitize his body and his brain to the memory of that motor vehicle accident. And then afterwards, we did little bits and pieces around reminders or things that just kind of set him off around desensitizing and doing an exposure framework around that. We also did like a graded exposure task to drive past that kind of location. And the first thing we did was actually just use Google Maps. So we did it in session, and using the street view, we just kind of got through it. And even as we were doing through street view, his mind was kind of racing, playing through things. And so we were kind of doing that with the intention of teaching his body and teaching his brain, you're at home, you're just looking at this, on your computer, that you're safe, and helping his body just to kind of recalibrate that this location is not as dangerous as it's making it out to be, that there's no need to kind of heighten this kind of stress response around this one thing. And he had quite good effect and he was responded quite well to this for his post-traumatic stress symptoms, and then we moved on towards pain education and around the whiplash and the kind of pain issues afterwards as well. So I've talked a little bit about some of the kind of psychological therapies that we do, but some of the things that you might have heard, as I said, is CBT. And CBT is almost like this kind of catch-all therapeutic modality that a lot of psychologists use now. And so sometimes you might want to just inquire a little bit if somebody is seeing a psychologist, what kind of CBT they're doing, because there's like second wave CBT, which is a bit more kind of old school or traditional from the 80s and 90s. And then what we call like the third wave of CBT, which is actually more of the values focused, bringing in some of the newer understanding of human suffering towards helping people as well. So it isn't as kind of rigid as, challenging your negative thinking or kind of scheduling positive activities. It's kind of anchored within recognizing that our thoughts and our emotions are useful at times, but sometimes it can also get in the way of that. So how we can be more flexible with our thinking, rather than saying your thinking is wrong. It's more about framing it as how do we be more flexible in our thinking or more balanced in the way that we're seeing the world or believing things. As well as anchoring it to your values, what's important to you as a person, and how do we kind of help you to head towards, make moves in that direction. And that was really informed by acceptance and commitment therapy, which is about your values and about accepting that the thoughts, the emotions that arise, that's going to happen because you're human. We can't fight, and the more we struggle with ourselves, the more we kind of actually pound on more distress. And so if we can just kind of accept that this is going to arise in my body, this discomfort or these kind of negative emotions or this kind of these thoughts, right? But acceptance doesn't mean resigning or giving into it. That's why it's not just called acceptance therapy. The commitment side is about saying, even if that's showing up, how do I commit myself to things that are important to me? How do I kind of live a fulfilling life while still holding space and holding room for these uncomfortable feelings or these uncomfortable thoughts that are showing up? So these two kind of modalities are quite helpful for depression, anxiety, and stress-related symptoms, and around that grief as well, that kind of adjusting to the new reality. But in terms of the evidence-based approaches for trauma, you might have heard of PTSD and then CPTSD. So this is called complex PTSD. I've had a few clients, especially in the back end of like a motor vehicle accident, where it wasn't just the motor vehicle accident, it wasn't a single event trauma. They may have had a background of feeling helpless back in their life through abuse, through neglect, or they might have had a series of kind of quite distressing or difficult accidents in their life, of life-threatening injuries. And so that's kind of compounding trauma upon trauma that makes this kind of presentation of PTSD a little bit more complicated than, I guess, your straightforward single event PTSD. But some of the evidence-based approaches that we might also employ include trauma-focused cognitive behavioral therapy. So the difference between CBT and trauma-focused CBT is that there's a trauma lens on it around the memory network, around how we kind of help to resolve or improve the distress around those associated triggers and the memory. And this can include things like prolonged exposure, which is about actually getting a person. I like to think of this as like hard mode or challenge mode in some of the trauma therapies, because you're really asking a lot of your clients, right? You're asking them to retell the story with their eyes closed, almost relive it. And this is the kind of endpoint. You might start with eyes open in third person and record themselves saying it and listen back to it over and over and over again to kind of desensitize and to habituate in the kind of stress response around that memory network. So sometimes clients can get a little bit put off by that, but luckily we have a lot of other approaches as well. So there's a thing called cognitive processing therapy. This is quite helpful when it's the meaning of the event. So it's not necessarily the flashbacks themselves of the intrusions, but it's more the kind of cognitive aspect. It's more about the, nobody can be trusted on the roads anymore, or I'm never going to be safe in a car again, or the insurers are out to get me. So the kind of cognitive processing therapy, my life's ruined, to kind of rewrite the narrative of their life, or to kind of look at what are the factors that are driving the kind of unhelpful beliefs that are driving some of the symptomology, and how do we kind of help that. So with cognitive processing therapy, we'd often get people to write what we call an impact statement, which is about saying, what happened to you and how has it affected you? What happened to you? How has it affected you? And so we get the person to write down all the things that came up from that, and then you pull that apart to say, okay, so you said here that you can never trust drivers on the road again, and then kind of pulling that apart to challenge that, to be able to kind of find a more balanced way of seeing driving and being on the roads. as an aside or as a different kind of modality as well, so this cognitive therapy for PTSD, it's a little bit similar, but also a little bit different to cognitive behavioral therapy. There's less of an emphasis on like our SUDs or our distress levels, and more of an emphasis on the kind of cognitive meaning and interpretation as well. So these are all evidence-based approaches. And then finally, you may have heard of EMDR, or eye movement desensitization reprocessing. It was a bit of hot stuff in the past decade in terms of gaining traction, gaining evidence base for it. And it's a little bit different to those kinds of therapies, those traditional talk therapies. So eye movement desensitization reprocessing, or EMDR, how it came about was Francine Shapiro. She was diagnosed with cancer while doing a PhD, and she was just walking out feeling quite distressed from her hospital consult. And as she was walking through a field, she was just seeing these kind of two people throwing a football from one side of the field to the other side of the field, and just tracking that with her eyes. And she just noticed herself feeling less distressed about her cancer diagnosis as she was tracking these two people throwing the ball across the field. And that's kind of what sparked her onto kind of really investigating and looking into, and then developing this kind of protocol for post-traumatic stress disorder. But also we now know it's kind of been extended for chronic pain as well, which is pretty cool. And so the benefit of this is that it doesn't necessarily require people to talk through their experiences. They may still have to confront it, but they don't have to verbalize it. And it's a helpful way to help through bilateral stimulation of the left and right parts of the brain and the body. The mechanism still being debated, but it's helpful to help to reduce the kind of distress associated with traumatic memories, and to kind of form newer and more helpful beliefs about themselves and the world as a result of that as well. And just as a small little aside as well, for people where, especially around that CPTSD or complex PTSD, if there's a history of like child sexual abuse or just like chronic kind of traumatic incidents as well, there's this kind of modality called imagery rescripting, which has been helpful for that. And so sometimes with whiplash, if it's like, and motor vehicle accidents and PTSD, what might look like a simple PTSD might actually have a few things that are underlying that or driving that or keeping that up. And so with some of the trauma therapies we might have to do is we have to go further back in time still to kind of resolve or to process some of those traumatic situations before it can kind of give and kind of let the kind of PTSD around the motor vehicle accident improve. So I've talked a lot, but really, and wrapping up and sharing this quote from Oprah, that lessons often come dressed up as detours and roadblocks. Most people, they wouldn't have wanted this in the first place. They probably wouldn't have wanted to see a psychologist in the first place. But thankfully, most people also recognize by the end of treatment, the gains that they've made, or they kind of have this newfound appreciation for their bodies and for life and for their values and what's important to them. And so I sometimes have to hold this in view as well, especially in the early stages when a client might be very frustrated or still navigating that system, is that, sometimes lessons come dressed up as detours and roadblocks. So from a psychological perspective, please consider a referral to psychology, especially if you're picking up on that kind of elevated distress, that catastrophizing, difficulty managing the impact of pain on somebody's life, or that grief, that sense of just difficulty adjusting to this kind of new normal. As well as any kind of comorbid mental health issues, especially for those post-traumatic stress symptoms. So we're thinking intrusions. So if you're asking them about the sleep, they're saying about really shit sleep at the moment, really poor sleep, just asking, what's kind of disturbing your sleep? And if they just kind of look on the lookout for any intrusions, if it's nightmares, and also any of the avoidance, the changes in thinking, feelings, and behavior. And finally, as a kind of in the kind of primary care, in the kind of early stages, really being mindful of our language. What we call those thought viruses, which can really embed their way into that threat processing model and really kind of make it harder for clinicians down the track to be able to kind of work and to help and to improve this kind of threat processing of their own body. So things like, you'll never get better. You've got the back of an 80-year-old. And if you feel confident with your, patients as well, being able to catch them, if they say, I've got a bunged up neck, or my neck's busted, or my shoulders, doomed, right? Just to kind of be able to reframe that or challenge that temporarily or in the moment can be quite helpful in the long run as well. So some kind of sample phrases might be, slow and steady, right? The body is a healing machine, normalizing that, if it's only like, 2 weeks after the motor vehicle accident crash, I think anybody would feel that, but also, we also know that our body's really capable of healing. So just take it easy and we'll kind of see each other in a few weeks' time. And one thing that I wanted to share as well was a study with oncologists, where they had two groups, one group which was the control group for people with breast cancer, and one group where they just kind of gave this intervention to the oncologist to say the script that this might seem like a really scary time right now, but I want you to know that you're not alone, and we're going to navigate through this together. And they just found by asking the oncologist to say this, and genuinely, of course, the perceived anxiety and the kind of distress levels of patients in these two groups was a lot lower for those where they had this kind of script than the kind of usual care. So it can really help with that anxiety, with that reassurance, and that can reduce that threat response further down the track as well. I've attached that kind of pain catastrophizing scale here, and also a nice little PTSD-8 scale, which is just some quick and dirty items. That impact of event scale that Rob was saying as well, that's also perfectly valid too. But these are two scales that can be quite helpful just for screening these areas that might be conducive or helpful for onwards referral through to psychology. And then in terms of some other resources, so as a general resource around psychology, the pain management workbook is a really great workbook that's been ticked off by a lot of kind of big names in the field from psychology. And there's also an app called Curable that comes with a lot of neuroscience education and some mindfulness activities, a lot of different things that people have found helpful in terms of managing and learning about persistent pain. And then, yeah, Rob's already mentioned that Whiplash resource. So there's actually a stress management section in there, so a psychology section in there too. So that's quite helpful to provide for patients as well. And that comes to the end of my talk. Thank you very much for listening in.
Thank you, Lan, for a wonderful presentation there. I am mindful of time, so I think what we might do is just go through maybe the first two questions, and then we better wrap up for the evening. So the first question that we had was, could you talk about whiplash risk and advice for adolescents in particular in relation to sport, e.g. soccer, goalie players, water polo players, or rugby, as often these kids do not realize that they could be injured and keep playing? Rob, we've still got you on mute there.
Yep.
Excellent.
I don't quite understand the question, but yeah, there obviously is inherent risk. Soccer's and there's been a lot of evidence and research of in concussion with soccer of the repeat, the lower level asymptomatic head blows, but on repeat incessantly then can lead to getting concussion symptoms with a smaller incidental bump. But I suppose one thing we know is in concussion, there's not a lot of evidence, not a lot of research on whiplash in adolescents, but in concussion, we know that there is outcomes seem to be more delayed in adolescents. And one thing we do know in concussion that we need, that probably one of the most important things we need to make people aware is if they suffer a concussion, they have symptoms, and their symptoms, let's say, have resolved, there is this period of time after symptoms have resolved that there is still physiological and chemical dysfunction happening in the brain. And so they're asymptomatic, but they're still at higher risk that if they suffer a subsequent concussion, way more likely to have delayed symptoms. So, this is that second hit syndrome that they call it, and so it's one way to mitigate that is it's used mainly in more professional sport is baseline testing. So in some semi-professional sports can be done. So all the athletes are tested before the season, before anything has happened. So you've got a lot of normative data for that individual person, so that if they do suffer a concussion, you can advise on return to sport based on comparing their pre-season numbers. I know in Canada, in ice hockey, every single player that's on the ice from childhood all the way through to professional levels, it's mandatory baseline testing. I think that's probably where the future's going in our sport in Australia. Obviously not in the sporting sphere. It's going to be pretty hard to get everyone driving cars to do that. But yes, we look at symptoms as a guidance for things, but certainly in concussion, we know the risk is still there for a period of time after symptoms subside. Hope that answers something.
Yes, thank you, Rob. That was very helpful. We'll just do one more question. So the second one that came in was, do hospitals/ED recommend specialist physio advice after discharging people following accidents where whiplash is possible?
Not in my experience of seeing that regularly. I think they're also somewhat tied in the past to recommend specific physios. I do know that they do recommend physio. I think I have had the odd person specifically referred to me from A&E. But as I said, this is relatively new in the research. This is the new guidelines that are coming through. So that may change more in the future. For acute whiplash, every physio has the skills to treat it, and just the more we can get the education out there about the guidelines, and we follow it, the better.
Thank you for answering those questions, Rob. I think we better wrap things up for tonight because I'm just mindful for time. So I wanted to say a thank you to all of our attendees for joining this evening, and an even bigger thank you to both Rob and Lan for such excellent presentations this evening. We really appreciate the hard work that goes into them. Just a couple of things before we wrap up for the night. The final physio webinar in this series will again be held at a 7 p.m. time slot, but date to be confirmed. So look out for details to come. Just a reminder again to fill in your post-webinar evaluation survey and to report your CPD hours, and that resources, presentation slide, and YouTube recordings will all be emailed to participants who complete their evaluations. And that's it for this evening. Thanks very much, everyone.